So I'm very happy to be here with you today. My name, as was just said, is Priscilla Lamoichan. I'm a professional scientist at l'Institut d'Excellence en Santé et Services Sociaux, which is an HTA organization in Quebec, Canada. So you also know my directorate who just spoke, Marie-Claude Serrois. So the objective of this webinar is to share with you some methodological challenges that we have encountered when we were attempting to integrate various forms of knowledge in evidence-based recommendations. So whether it be scientific, contextual, or experiential knowledge. We also wanted to share with you some opportunities afforded by this process that has allowed us to adapt the clinical support tools that we develop in the hope that this will facilitate uptake of recommendations by practitioners. So before diving into the core of the matter, I will briefly present our HTR organization and an overview of how we perceive knowledge integration. Then I will share with you some examples of how we integrated various forms of knowledge in a project that we recently conducted, as Marie-Claude said, a project on delirium. And hopefully this presentation will provide some grounds for discussion with you afterwards, as this is somewhat a new endeavor as we try to develop guidance that meets the needs of practitioners. So you will often hear us saying the acronym INES, which in French stands for Institut National d'Excellence en Santé et Services Sociaux. Our institute was established in 2011, and it was created by a law. The institute functions as an independent governmental agency. It has a board of directors, a scientific council, permanent deliberative committees, and a users and caregiver panel, and 8 directorates. There are about 270 employees at the present time, and l'INES has a yearly budget of about $35 million, which is approximately 23 million euros. And last year, we published a total of 257 scientific publications. So this gives you an idea of our organization. And overall, our mission is to promote clinical excellence and also the efficient use of resources in the health and social service sector. So we aim to be an essential reference for informing decisions and practices. And our values are those of excellence, independence, openness, scientific rigor, transparency, integrity, and equity. So we have various mandates that are actually written in our law. These mandates are to assess clinical advantages and the cost of technologies, medications, and interventions. We also prepare recommendations and develop clinical practice guides. We aim to determine service performance evaluation criteria and, if applicable, service implementation. We also have to keep our products up to date, to distribute and publish them, of course, and to foster the implementation of recommendation and practice guides. So the example of knowledge integration that we will present today is in line mostly with the second mandate, because we developed clinical practice recommendations, but we were a little bit more creative and embedded the recommendations in clinical support tools in formats that we hope are better adapted to the needs of practitioners here. The project is also in line with the fifth mandate, as the project went a little further than we usually do in supporting implementation of best practice recommendations. So at l'INES, we use an approach which is based on global value appraisal. We view an intervention or technology as providing value when its use or implementation actually contributes to our health and social service system. So this appraisal starts with first determining the relevance of the health or social service issue that was brought to our attention. And once the relevance is confirmed, we then engage in a scientific process that includes mobilization and integration of knowledge. And this is the particular process for which we will be providing an example today. So once the knowledge has been integrated and we have developed evidence-based recommendations, we submit our work to a multidimensional deliberation. We won't have time today to talk about this specific step, But let me just say that this step is done to ensure that our recommendations are just and reasonable for the healthcare system globally. So our system is very saturated. I'm sure you can all acknowledge that. So many healthcare needs need to be attended to. Our population is aging. There's labor shortage in many sectors. A lot of evidence-based recommendations that practitioners need to deal with. So we really need to make sure that what we put out there is very relevant. And finally, once our products are distributed and published, we also aim to assess their impact on practice or more globally on the healthcare system. So at Linus, we develop different types of products. We write reports without recommendations, and that would be your usual literature reviews. We also do current states of practice reports. And a second type of product that we produce is the reports that include recommendations. And those are scientific advice for the Ministry of Health and Social Services. And we also develop guidance documents and clinical management support tools for practitioners. So today we are particularly interested in sharing and reflecting with you on the methodological challenges and opportunities that are related to the development of clinical management support tools for practitioners. So when we develop this type of product, we do that by integrating various types of knowledge. Of course, we examine scientific literature using various approaches to literature synthesis, but we are also interested in integrating contextual knowledge, which is knowledge that key stakeholders share with us and that help us to understand the clinical or social context surrounding the problem we are addressing and how to best adapt our recommendations to this context. We do that because at the end, we want to make sure that our recommendations that we issue are adapted to the healthcare and social service context here in Quebec. And we want practitioners to use our reports or tools and not to put them aside because they feel that what we produce does not apply to their practice. We are also convinced that integrating experiential knowledge from people using healthcare and social services, as well as their caregivers, often helps us to understand their perspective and their experience of healthcare and social interventions, as well as it helps us to understand the impact that our recommendations might have on them. They often help us to enhance our best practice recommendations in ways that will be acceptable and beneficial to them. So you see our circles here are intertwined. So we really try to integrate the three types of knowledge in our products, as opposed to adding one or prioritizing one type of knowledge over the other. So our support tools are really the product of this integration. Now I will present some of the challenges and opportunities when we attempt to integrate knowledge, and I will do this by providing an examples from a project that we have recently conducted, and in which we develop clinical support tools for the prevention, assessment, and management of delirium in the elderly person in the emergency department. So first of all, here's the question that needed to be answered that guided our entire work. So what are the best practices for the prevention, assessment, and management of delirium in the elderly person in the emergency department? And how can these practices be adapted to Quebec's healthcare context? So what is delirium, first of all, and why was this question so relevant for the patients, the practitioners, and the healthcare and social service system? Well, delirium is a state of confusion. It manifests itself as a disturbance in attention, awareness, cognition. It usually comes on very suddenly. It is an acute condition, and it can last hours to days, sometimes even longer. We can observe three types of delirium. You will see a hypoactive form, where the person is slow, lethargic, and this is the most frequent form, but the one that goes most often unnoticed. There's also a hyperactive form, where the person is agitated, hypervigilant, and can sometimes be aggressive or have hallucinations. And you'll see a mixed form where the person can alternate between the hypoactive and hyperactive state. So the consequences of delirium are serious. There's an increased risk of morbidity, mortality also, and the person is more at risk of prolonged hospital stay, and at an increased risk of being institutionalized after having a delirium. So delirium is a medical emergency. There are studies that were conducted here in Quebec that show that delirium is not detected in up to 85% of cases occurring in emergency departments. So the impact on the person and the caregiver is considerable. And what also poses a challenge to evidence-based practice here in Quebec is the context of the emergency department itself. So in Quebec, our emergency department is full of people waiting. It's not unusual to wait sometimes 10, 15, 24 hours or even more. It is an extremely busy environment, noisy, often no windows. So it's really a harsh environment for the elderly person, and it can itself precipitate delirium. So in this project, furthermore, we were also sensitive to the caregiver experience because they are often present to accompany the elderly person in the emergency department, but they can actually be of help in preventing delirium, and they can also be involved in supporting the person who has a delirium. So to help us answer this very important question of what are the best practices and how we can adapt them to Quebec's context, we collected knowledge from a multitude of different sources. Of course, we examined the scientific literature, but we also collected contextual and experiential knowledge from various stakeholders. So in this project, we had an advisory committee, a monitoring committee. We also consulted our service user and caregiver panel. We also conducted a consultation with caregivers who actually were there in the emergency delirium department with an elderly person who experienced delirium. We further consulted practitioners to have feedback on the tools we developed, and also 2 emergency department teams piloted our tools. So finally, a project was presented to our multidimensional deliberation committee, and our entire work was reviewed by external reviewers. So after this whole process, we published 4 tools: a clinical management support tool for practitioners, which includes all the recommendations, a memory aid, which is a summary of the recommendations and that fits into 1 page, an algorithm, which represents the decision-making process and also fits into 1 page, and an info sheet for caregivers. So in the next slides, I will share with you how we collected knowledge and how the integration of this knowledge led us to develop these 4 tools. And I will give you some insight into the opportunities and challenges that we have faced. So for the delirium project, we used a rapid review approach to literature synthesis with the usual steps of searching, selecting, and extracting. We also assessed the quality of evidence and synthesized the information gathered into evidence statements. Each statement should normally lead to a best practice recommendation. So for the delirium project, early on, we discovered that there was quite an extensive body of literature. This can pose a challenge when we attempt to balance time needed to appraise the literature and the expected timeline so that our clinical support tools can be published in a timely manner. Fortunately, in this project, the evidence had been appraised many times before, so we took the opportunity here to restrict our review to clinical practice guidelines, and we found guidelines on management of delirium for the adult and elderly populations in hospital settings. However, because the context of the emergency departments is quite different from other hospital settings, our advisory committee suggested that we should also look into systematic reviews targeting specifically practices in the emergency department. So we went back to the literature and found systematic reviews and scoping reviews addressing 1 or more aspects of the management and of delirium in the elderly population in the emergency department. After that, one of the committees that we set up at the very start of the project is our advisory committee. For the delirium project, we recruited 2 researchers with expertise in delirium in the elderly and 10 practitioners. This committee closely collaborates with us at the start of the project until the end of the project. They're involved in project orientation by giving us feedback on the project protocol, Then they also review the evidence statements that emerged from the literature synthesis, and they review the clinical tools that we develop. So consulting this advisory committee is an opportunity for us to obtain feedback on our methodology, and they also help us to anticipate challenges upstream that might influence how our recommendations are going to be perceived or accepted by practitioners. They also help us to understand and consider implementation issues early on. For example, in the delirium project, they clearly expressed that the emergency department context is a fast-paced environment, and practitioners are constantly triaging priorities, so that practitioners need to understand that delirium is a medical emergency, but they need tools that are clear, straightforward, short. So this was at the back of our minds throughout the project and influenced many decisions that we made. For the delirium project, we also set up a monitoring committee. This committee is composed of representatives of professional regulatory boards or associations and representatives of the Ministry of Health and Social Services. We consulted this committee at the beginning of the project, so we presented the project protocol to them. We also consulted them at the end of the project to have their feedback on the clinical tools that we developed. So this is an opportunity to make sure that the type of recommendations likely to emerge from our work aligns with the scope of practice of the target practitioners. And this committee also helps us to identify strategies to disseminate our work afterwards to make sure that our clinical support tools will reach practitioners. A challenge that you might encounter here is that some topics might be more prone to interprofessional disagreements, but setting up this type of committee can also help you to understand the gray zones and be more sensitive in the way you might write the recommendations. Next, in our organization, we have what is called a service user and caregiver panel. This is a standing committee. Therefore, there are 4 members who are either users or caregivers with various experiences in the healthcare system. And because this is a standing committee, they are quite familiar in general with the type of work that we do here at l'INES. However, they do not necessarily have personal experience with the health or social problem addressed in every project. So in the delirium project, this was an opportunity to take the time with them to reflect on how best to integrate perspective of users and caregivers in our work. We knew that we aimed to develop a clinical management tool with clinical practice recommendations for practitioners, but we were unsure if the perspective of users and caregivers could be integrated in such a tool. After a discussion with them, the members of this panel strongly recommended that we consult the caregivers of persons who had a delirium episode in the emergency department rather than the users themselves. And the caregivers would surely be able to provide perspective on how practitioners could meet their needs and the needs of persons in delirium. So when consulted this panel, scientific teams often face the challenge of finding ways of explaining in layman's terms sometimes quite complex projects. So that would be a challenge here. Upon the recommendation of the panel, we organized a caregiver consultation. We were able to recruit 7 caregivers, and we organized a one-time focus group. Throughout this consultation, we found out that this was an opportunity to really understand how some of their needs are not being met at the present time and the impact that it had on the person who had the delirium and the caregiver. They expressed that they wished they could have been more informed, but also consulted and involved in the care when possible. A few challenges here is how we go about to recruit these caregivers. We found that social media networks of patient organization usually works well. However, you have to be mindful that some organization can have some very strong one-sided opinions. Sometimes something that might also be a challenge is finding within your scientific teams professionals that have the skills to lead a focus group or perform interviews with users and caregivers. It takes good interpersonal abilities and the ability to show empathy because the users and caregivers have sometimes experienced very difficult situations. And another challenge is how do we translate the needs of users and caregivers into practice recommendations? Okay, so now that we have gathered all this scientific, contextual, and experiential knowledge, we get to finally put all this knowledge into clinical support tools. And here are like three main questions that we asked ourselves when we were developing the tools. How do we structure the tool? How do we write the recommendations? And how do we format the tool? I will give you just one or two examples of how we integrated the knowledge for each of these questions. So first, how did we structure the tool? After the literature synthesis, you have to know that we had about more than 70 evidence statements grouped into about 15 clinical steps. Our advisory committee recommended that we should, of course, follow the clinical process in our tool, but to keep the steps as simple as possible. 1, 2, 3, that's what they told us. So fortunately, we were able to group the recommendations into 3 general steps. So preventing delirium, assessing delirium, and managing a person with delirium. And within each of these larger steps, we included 2 or 3 substeps. We even chose purposefully 3 different colors for the 3 different steps so that practitioners can easily find the information they are looking for when using our tools. Now, how did we write the recommendations? So after the literature synthesis, we had evidence statements that are written in a very general or neutral form. For example, we had an evidence statement that reads as follows. Clinical practice guidelines recommend that practitioners rapidly identify older persons at risk of delirium by looking for the presence of risk factors. So when we had to write a draft recommendation for the clinical management support tool that would be addressed to practitioners, we tried to shorten the sentences and to use verbs of action. For example, in this statement, evidence statement was transformed as follows. Upon initial contact with people 65 years and older, look for delirium risk factors. So you see, it was quite shorter. But then when we showed this to our advisory committee, they told us that screening all persons 65 years and older would be difficult to implement because it would mean screening a large proportion of patients in our emergency departments here in Quebec. So to facilitate the implementation, they suggested to target persons 75 years and older, or those with 65 years and older with a geriatric profile, as they felt these persons are more vulnerable. So therefore, the final recommendation in our tool read as follows. Upon initial contact with people 75 years and older, or 65 years and older with a geriatric profile, look for delirium risk factors. So this is an example of how we integrated contextual knowledge from our advisory committee. Now another example on how we wrote recommendation, but this time integrating caregiver experiential knowledge. From the literature synthesis, we had an evidence statement which said that clinical practice guidelines recommend that practitioners inform patients and caregivers about delirium and preventative interventions, that caregivers be involved in implementing non-pharmacological interventions. So during caregiver consultation, we were able to gather more precisely what type of information they wished they receive. We therefore included a section in the clinical management tool specifically reminding practitioners of the type of information to share with the elderly and their relatives. As you have seen earlier in the delirium project, we developed 4 clinical support tools. The first that we developed was the clinical management support tool, and it contains all the clinical practice recommendations, and it holds in 9 pages. As for the other tools, their development really emerged from the needs expressed by our advisory committee and caregiver consultation. So our advisory committee said that the practitioners in the emergency department needed a tool that is a quick reminder of the most important recommendations, and it had to be a 1-pager. Therefore, we developed a memory aid, which is basically a summary of the recommendations. And in the memory aids, we inserted links to the clinical management support tools so that the practitioners can easily retrieve the more detailed information if needed. Then nurses also expressed that they needed to have the decision-making process on one page and that they often use algorithms in their work and that it helps them. So as it could apply to the delirium management, we decided to develop an algorithm which also includes links to the clinical management support tool. Finally, throughout this project, emergency department practitioners often express that they lack time, which makes the uptake of recommendations difficult. They told us that practitioners might have difficulty in fully applying the recommendation of sharing information on delirium with the patient or the caregiver. So to support this best practice, we developed an information sheet that clinicians can give to caregivers when it is indicated. So now that our tools were developed, our work wasn't quite finished yet. So we submitted the tools to a validation process where we ask future users of the tools, so in this case, emergency department practitioners who are not involved in the project up to now, to comment on the tool. So we send them the tools by email and ask them to complete a questionnaire. So this is an opportunity to ask practitioners if the tools are clear, easy to understand, is the information well organized, are the tools complete or any information missing, is the level of information appropriate for them. So in this project, we went even a little step further because we were quite preoccupied by the implementation of best practices. So we asked two emergency department teams to actually use the tools for some time in their practice and to give us feedback on the tools. So as I just mentioned, we're quite preoccupied by the implementation of best practices that were recommended in our tools. And why so? Well, first of all, delirium best practices require the involvement of a multidisciplinary team. So there are recommendations in there that are non-pharmacological and some that are pharmacological interventions. But most of the interventions are not restricted to only one profession. So you really need to have the whole team uptake the best practices. Also, different stakeholders throughout the project clearly express barriers to the uptake of evidence in the emergency department context in general. And one important challenge that stakeholders expressed is that it will need a culture change in professional practice that needs to happen to be able to really prevent, assess, and manage delirium appropriately in the emergency department. Therefore, our organization reflected on how we can support implementation while also keeping within our mandate as an HTA organization. So our scientific team and our knowledge transfer team collaborated to develop 3 implementation tools, support tools. So the target users of these tools are not the practitioners. These tools are meant to be used by persons who are responsible for the implementation of best practices in the different healthcare organizations. It can be, for example, managers or clinical practice advisors. So we developed first a questionnaire on barriers and facilitators to the implementation of best practices. We also developed a reflective tool on practitioners' roles and responsibilities in delirium management, and a reflective tool on practice gaps. So we won't have time, I think, today to go through the details of the development process for these tools, but I will say that this was an opportunity to combine scientific and knowledge transfer expertise. We feel that we are maybe one step closer in helping in overcoming expressed barriers. And since we are a HTA organization at a provincial level, the publication of these tools can reach maybe a wider audience. I will say that one challenge here was really to reflect on our mandate as an HTA organization and gauge where in the cycle of implementation process we can be pertinent and useful for the healthcare system. So now to conclude this presentation, We wanted to mention a few more overarching challenges that we faced in our organization as we move towards knowledge integration. There's always the challenge of recruiting the appropriate stakeholders to have the appropriate perspectives that we need in a project. We are also often have to deal with a large amount of information, but we have timelines to respect. Weighing different types of knowledge can also be a challenge, and we sometimes have to deal with conflicting perspectives. And lastly, choosing an appropriate qualitative approach to collect and analyze stakeholder perspective can also be a challenge. So I will stop here, but before we open up the discussion with you, I would just like to say that although I'm the only one presenting today, this project was made possible because of the work of our whole team and numerous collaborators. So I just wanted to acknowledge them and thank them. Now we can maybe open up the discussion, and if you have any questions, please feel free to ask them. I will try my best to answer them, and I have some colleagues here who can also help me. And if you want to share your experience, please do so. We're very interested in hearing what are the biggest challenges you have encountered in your organization and what solutions you have put in place to overcome them. Thank you.
Thank you so much, Priscilla. That was really interesting. So I'm sure there will be multiple discussions from, I think we're about 22 people from 5 countries together here today. So Marie-Claude, did you want to lead the discussion and then I'll keep an eye on the chat?
As you wish, Rigmor. Yes, I can. Is there any questions from the participant? There's a question from Asiatou. It's knowledge transfer experience. Est-ce que tu veux l'expliquer, Priscilla? Do you want to explain?
We have a team here at l'INES who have an expertise in knowledge transfer. So KT is knowledge transfer. Was that your question? Okay.
Well, I have a question. I'm just talking because I couldn't find how to raise a hand in Zoom. So sorry. But I was just curious. One of the challenge was dealing with conflicting perspectives. I guess can be between the different committees or between scientific knowledge and application and on the field. Do you have an example and how you decided to choose between this?
We tried not to choose. I'll attempt an answer. Maybe Marc-Claude can also pitch in after. Sometimes what we can see is, let's say, the different perspective between what we find in the literature, so the evidence that we synthesize from the literature, and maybe like users or caregiver perspective. For example, we look at the literature and we find that there's not a strong evidence for the effectiveness or of a particular practice, and then the caregivers or the patients, they will feel that this type of practice has actually helped them in their own lives. And what I think what we usually try to do is to make sure that we're all talking about the same thing. Sometimes either caregivers or our advisory committees, they don't necessarily understand our actual process, scientific process, and sometimes they need to be we need to explain to them the actual outcomes that we're looking at and how we do that. And when we explain more of our process, people often understand how we make those recommendations, and it's like that's how we integrate the knowledge, and we understand what they're feeling or what they're saying, but they also need to understand how we do scientific process. I don't know if that helps you to understand a little bit.
Yes, I do. And by the way, it was really interesting. Thank you.
Thank you for your question.
I raised my hand myself, and for those who may be looking for the hand, if you go to the bottom of the Zoom screen, there's an icon with a heart and it says react. If you press on that, you'll find the hand, but you don't need to raise the hand. It's not too many of us here today, so don't feel like you have to use it, but I decided to do it to write myself on the list for people who have questions. So to my question, I was really impressed with the number of different sort of outputs you had in connection with this work. So you have an algorithm, a memory aid, an info sheet, and more. And it appeared to me that these were targeted at different users. That seems like a really great idea, and of different length, different complexities, and meant for different users, as I mentioned. And I was just wondering if you could talk a little bit about whether this is something you do for most of your scientific work, and how did you end up with these different types of deliverables?
Michael, do you want to answer for most of the projects, and I can answer the second part?
Well, in INES, we have various sectors. We have the Directorate for Medication Innovation, and we have the health sectors and social services sector. In our sector, we're not that used to do those kind of tools, but it was kind of a practice for the health sector, and we kind of transferred the way they're doing algorithm, for instance, or very practical guidance in short guides for the practitioner themselves. And Delirium is one of the first production that we had all those different tools. But we realized with our stakeholder that they really enjoy them, and it's way more easier for them to implement best practices when they have tools like that instead of huge report that we used to do. We always had vulgarizations, but not necessarily as practical as the tools that we're showing you today. And for us, this is something we want to do more.
And I will just add that in the Delirium project, the recommendations that we were trying to put out there was not just for one type of professional. It was really like it could be used by different professionals. And so there was a lot of different needs that were expressed to us. So we tried, why we had maybe so many tools, that we tried to answer the needs of various people. So maybe in another project where it's more targeted to one type of professional, or the recommendations are not as extensive, you might not need all those tools. So we really went with the expressed needs of the people that we were consulting.
Thank you, Priscilla. And we just received a request from the Ministry of Health and Social Services. They want us to adapt those tools to different settings for elderly people, for other, how do you say that? Des milieux d'hébergement? Living care facilities.
Living care facilities.
Yeah. I think there's a question from Asia too. It's close to what you just asked, Rigmore. How did we end up with those 3 tools, and how long did it take to develop them?
Are we talking about the clinical tools or the implementation tools?
The implementation tools.
Okay. Yeah. Well, maybe I can answer for both, actually. We showed you 4 clinical support tools, which were targeted to practitioners. So we want practitioners to use these tools for their best practices. This took about, if if we think about the very, very beginning, when we started to write the protocol until the end where we actually published, it took about 16 months, I think. And when we talk about the implementation tool, I did not have time to show them to you, and they're only in French, those tools. Those tools are targeted not to practitioners, but to people who are responsible for the implementation of general practices in their organization. And those tools, we started to develop them a little bit later in the process when we actually heard all the barriers to implementation, and we started to think about that. So those tools, I would say, took maybe about 4 to 5 months to develop. But I'm estimating because it was a gradual process where we started to think about it throughout the project. Does that make sense, Marie-Claude?
Yeah, of course it does. Just the part for the implementation that we didn't show today, it was the first time for INES. So the knowledge transfer directorate, they also had to learn, and we did a lot of back and forth. But it's an example that we can transfer to other implementation opportunities from now on. So it took a little bit more time, I think, for us to adjust to how far did we want to go in implementation? Because it's not the responsibility of our organization to implement, it's the responsibility of the ministry itself or the different organization, health organization in the province.
Okay.
So the tools are not, the tools, the implementation support tools are not recommendations that we put in there. It's tools where the teams have to maybe, it's questions that the teams can ask themselves to see what are the barriers in their organization. Because Quebec is a large province, so the different regions have different challenges.
Reality.
Yeah, and realities. So it's really to help them to reflect on their process that they will need to do to implement the best practices.
Okay, so sometimes we can develop like self-evaluation tools for them, so it could be those kind of tools, right?
Yes, it's in this mindset, right?
Okay, thank you, and very interesting, by the way. Thank you.
Thank you, Asiatou.
Thank you.
Any other comment or question from participant?
I wonder if maybe I could have a chance to ask one more question, which is in sort of dealing with or finding a good way to balance or handle potential opposing or conflicting views that caregivers may have relative to what the evidence shows. So balancing conflicting, perhaps, pieces of evidence.
I don't know, Marie-Claude, if you have other examples. In Delirium, we were quite fortunate in the sense that the perspective of caregivers actually were quite aligned with the recommendations. It just helped us to really have a little bit more detailed information on what their needs were. But in other projects, that can happen where the perspective can be conflicting, and maybe Marie-Claude can add to that.
Yeah, it's a very interesting question, Rigmore. You know, some projects are very polarized, and opinion are very strong from different groups. We had one recently on autism spectrum disorder for a specific intervention where some people, they were really thinking that that should be implemented everywhere, and others were saying, well, no, because there's a lot of not that good outcomes, and we're unsure of efficiencies and all that. So it's always a hard process, and sometimes we cannot convene together, and they will keep their position, which is okay also because it's variety of position, and we make sure at that moment that there's different process. The first process is that we document what the people, the different position that we had throughout the project, so it's really transparent. We're not taking just one vision or the other. We're documenting in our report that there was differences of opinions. That's one part of our process. The other part of our process, we didn't discuss it today, but we can in some other time if you think it's interesting. We do have a group of person. We call it deliberative committee. And that group of person, they are official in our organization. They have a president, a vice president, they have a really specific mandate, and they do deliberate. So we bring them our results. We bring them our reflection. Where do we stand? What are the challenges we're facing in that specific project? And they're kind of a wise group that make us reflect upon different dimensions, on the clinical dimension, on popular dimension, on values of society, on ethical matters, and on economics also. So those are multidimensional, and we have Olivier today, which can join and explain a little bit more also, because he has he is experienced in that matter. He is a coordinator, scientific coordinator, and the multidimensional is really by his leadership in INES. And so if you want to join in, Olivier, I don't want to put you on the spot, but that group, we discuss, deliberate with them. And at the end, we're trying to convene with them. And if we don't, again, we document the various perspectives. And finally, INES is responsible of the final recommendation. And if there's still so much uncertainties, then the way we're going to write our recommendation will be a mirror to that. So I don't know if I was clear enough. It's always a little bit hard. The multidimension, I didn't translate them properly. Olivier, help me a little bit here. We have the clinical, we have populational values, we have economic value, economic aspect, and then the two other ones in
the
English.
Organizational, the populational, the social, cultural, and and those who you said before. As Priscilla said before at the beginning of her presentation, since we adopt a global value approach to our evaluation of intervention, it's a matter of an equilibrium between each dimension, because one intervention can bring value on all, or can bring more value on the clinical side and less on the economic side because it's really expensive, for example, and since it's covered a lot of people, it could bring difficulty on financial difficulties for the public health system. So just to add, since on what's said before, it's a orientation for us. It's not a prescription. I want to say is that we tend to have this 360 vision of intervention, because we think that HG agency, the added value of our activities is bring that kind of perspective on intervention, because other actors work only on clinical side, other actors work only on the implementation, organizational or economic, but value of HG agency, we think that is really to bring that global approach, first of all. And after this, it's the same for many of your agency. I think that HAS, ISI2, you have the Commission sur la Transparence, you have other commission, advisory committee, NICE, etc., etc. So we in each agency, we also have this vision of it's a group of people that is representative, a matter of speaking, but bring a diversity of perspective that will assess the final products, because the team of Priscilla is the expert of integrate all those knowledge as she presented, the integration of contextual evidence, the integration of experiential evidence, the integration of the literature review, and that's our expertise of our teams. And after this, it's bring those knowledge, those all those evidence that was translated, integrated, summarized on this table, and the deliberative committees have the difficult job to assess all of that, but to also help us to make recommendation on different type of the different aspect of the intervention that is assessed. So it's a chain, or it's a process that each activities that bring evidence together to assess those evidence and to develop specific guidelines for decision maker, clinicians, healthcare, etc.
I just shared the translation of our dimension because I was looking for my English word. So it's the clinical dimension, populational, economic, organizational, and social cultural, and you have a bit of the definition underneath. And it's not only Ines who does multidimensional. It's recognized in literature for best practices and implementation in real settings. So and underlying this, it's also all the ethical aspect, but and it's progressing also. We're bringing all the equity consideration and populational dimension, for instance, and the real setting for all the contextual goes to the organizational dimension. So it makes our product more applicable in reality by doing so. So we don't end up just with the best practice. We also put them inside of that reality check and that ethical concerns that we have for our recommendations. So I just stopped the sharing. Thank you so much, Olivier. I put you on the spot, but you did well. Thank you. Is there any other question or there's people from Ines also. If you want to join in, add up information, feel free. There's 3 minutes left.
No more questions in the chat as far as I can see. And as you said, Marie-Claude, 3 minutes left. So still time for people to...
If there's 3 minutes left, I have a question for the you called it but the organization that were in the committee with clinical professionals. Don't know how you called them.
The
was it all
advisory
from
committee?
the same? Pardon me? Yeah,
The advisory.
committee. Yeah. Was it all from the same organization, or were they from different organization? And these people, when after you gathered the data, did they continue using the tool in their permanently, or?
So the first part of your question, we try to have people with different perspective. So we don't take 2 person from the same organization. We try to have people from different organization and from various regions in our province in Quebec, so we can have the different perspective and the different challenges that people are actually faced with. So the professionals that were on our team, they are also from different professions. So there's a different type of layers there. So you have to have people from different professions, because the delirium was a problem that's is addressed by different professions, different organizations, and different regions.
Yeah.
So this is for the first part of your question.
Mhm.
And what was the second part again of your question?
Well, after you gathered the data or stopped working, do you know if they continued using that tool permanently, or for the was it durable, the change?
Well, at that, there's two level of answers for that. The first one, it's the ministry is responsible to make sure of implementation, and they can ask the organization to implement the tools that Ines produce. It's the responsibility of the ministry. Maybe it's going to change now, but I'm not going to explain it today. The other thing is we also are really interested in having feedback from organization and from practitioner if our tools are useful. And delirium is going to be one of our formal impact evaluation that we're going to do. So it helps us to reflect on how we work and if it's making real changes in reality, because that's our real aim, is to support the practitioner and the patient, the user, and their caregivers.
Thank you.
Thank you so much. Priscilla, you did great. It was very interesting. And thank you to Encia Rigmort for your Master of Ceremony. I really appreciate it. To participant that came here today. And don't worry, if you have any questions or you want to have a discussion, you want us to share things with you, either on this subject or other subject, don't hesitate to give us a chat, an email, whatsoever. It's always a pleasure to collaborate and to share experience, and also to receive experience from you guys. So thank you so much for your participation today.
I second that. Thank you so much, everyone, and happy weekend right around the corner.
Thank you.
Right around the corner.
Take care.
Bye.
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 Bye-bye.
Bye, everybody.